available in the chat box at the end of the lecture. And you can also type any of the questions in the chat box and we will have a Q&A session at the end of the session. So today we will have Dr. Roziana Abdullah. She is our specialist that graduated from University Malaya in 2002. She obtained her master degree in child dental health also from University Malaya in 2010. She has been working in various hospitals in Ministry of Health and currently she is working in Hospital Ampang. Okay. She is the chairman of the Paediatric Dental Hemophilia Committee Oral Health Program, Ministry of Health since 2019. Okay, without further ado, please welcome Puan Sri Dr. Roziana.
Okay, Assalamualaikum and good afternoon to everyone. Thank you, my beautiful moderator, for the nice introduction of myself. Short and sweet. Okay, so without further ado, I will share my screen. Let me see where I can share. Cannot see. Sorry. Can everyone see my screen? Can hello?
Not yet.
Not yet.
Boleh dah, nampak dah.
Okay. Sorry. So today's topic is about pediatric dental management for person with hemophilia. So I will short form the person with hemophilias with PWH lah. So whenever you see PWH in my slide, it refers to person with hemophilia. So basically, I want to give a disclaimer that 80 to 90% of my lecture is based on clinical practice guidelines of management of hemophilia 2018. So whoever has read or studied this CPG, you're welcome to leave the talk because actually 80 to 90% comes from it. Part of it, I get it from buku panduan hemophilia untuk jururawat. This one was established by hematologists in Hospital Ampang, and I don't have my actual patient who has hemophilia who I treated. So basically all the images I get from Google Images. Okay, so actually the clinical practice guidelines is very good. It's quite comprehensive and there's a few pages about dental management. So I'm going to share. So the next thing is I want to, in this lecture, 50% of my lecture is about us to understand hemophilia. Because I think if we don't understand what hemophilia is, then how can we manage it, manage it properly? We have to understand the disease, the underlying condition, so that we can have a proper planning to treat the patients. Okay, first and foremost, what is hemophilia? Hemophilia is an inherited blood disorders in which there is a lifelong defect in the clotting mechanism. So hemophilia has two types, which is hemophilia A and hemophilia B. Hemophilia A, as we all well aware, is a factor 8 deficiency, while hemophilia B is factor 9 deficiency. So this will bring us back to the coagulation cascade that we learned during our undergraduates. So where is the hemophilia, where is the factor 8 and where is the factor 9? So this one actually is just a revision so that just for flashback to know how it affects in the coagulation cascade. So basically, hemophilia was also known as a royal disease. It was first coined in 1820s by a student in Zurich University, Friedrich Hoff, I hope I pronounced it correctly, and his professor, Dr. Schoenlein. So originally, the term is hemorrhophilia, which is love for hemorrhages, but eventually in 1828 it became hemophilia. So it has been called royal disease because the hemophilia gene was actually passed from Queen Victoria, Queen of England, in 1837 to the ruling families of Russia, Spain and Germany. So from this Queen Victoria family tree, we can actually also notice that the current monarchy was not affected because King Edward VII actually was not affected by the hemophilia gene. Okay, so the current monarchy is not a hemophilias person with hemophilias. So it is actually inherited as X-linked recessive traits, which is males are affected because males only have one X genes, while females are carrier because female has two X genes, whereas one X gene is affected and the other X gene is normal. However, females can also be affected by this hemophilia condition. So a positive family history is present in 2/3 of patients, while another 1/3 may have spontaneous mutation. So 30% of hemophilia cases are spontaneous mutation, meaning no family history. It means the mother is not the carrier, and mutation happens within the patient themselves. So to understand the inheritance pattern, so it's actually transmitted from female carriers and also from affected male. So basically, like in these two inheritance pattern, you can see that the left one is the father with hemophilia, meaning the X gene is affected. So he is a hemophilia person. So the mother is not the carrier. When they get married, okay, none of the sons will have congenital hemophilia because the father only passed through the Y gene. So the X affected gene was not passed by the father. So none of the sons will have congenital hemophilia. However, 100% of the daughters will be the carrier because the daughters will get the X gene from the father and the X gene from the mother. But inheritance from a female carrier, whereby the inheritance from a female carrier, there's a 50% probability of the sons will have hemophilia and 50% probability of the daughters to be the carriers. So the mean prevalence of hemophilia A in Malaysia has increased actually from 5.6 per 100,000 males in 1998 to 6.6 per 100,000 males in 2006. The hemophilia B is lower. There's 1 in per 100,000 males, and prevalence for higher income countries was 2.69, while the rest of the world was 1.2. So hemophilia A and B in Malaysia is actually considered one of the rare disease. However, it is an important rare disease because of its financial implication, because of the treatment is expensive and very costly. And hemophilia A is 4 to 5 times more than hemophilia B. But you can see from this pie chart, 70% of hemophilia A and hemophilia B is on the severe type, which means they need comprehensive treatment and management. So what is the clinical presentation of person with hemophilia? Person with hemophilia, usually in the early childhood, they got easy bruising, spontaneous bleeding, particularly in the soft tissues, muscles, joints and gum, and excessive bleeding following trauma or surgery. Most common site of bleeding is the joints, especially the hinge joint, which is the ankles, the knees and the elbows, and frequencies, the most frequent site is the joints, which is 70 to 80%. The muscles is 10 to 20%, while others, including oral cavity, is 5 to 10%. Central nervous system intracranial hemorrhage is very rare. It's less than 5%, but it's very dangerous. Okay, so bleeding in hemophilia, in person with hemophilia, is considered serious if it occurs in the joints, or as also known as hemarthrosis. When the bleeding occurs in the joint, we call it also hemarthrosis. It's also serious if it's bleed in the muscle, especially the deep compartments, and also serious if it's bleed in the mucous membrane in the mouth, gums, nose, or genitourinary. Is this serious? But it is life-threatening if it's okay in the neck or throat because it can compromise the airway. This will include the floor of the mouth, the intracranial, and gastrointestinal. So relationship between bleeding severity and clotting factor level in hemophilia. So hemophilia condition, for us to understand it, we can actually classify it as I have shown in the previous slide about the pie chart where they have severe, moderate, or mild. So basically they can be classified as severe, moderate, or mild hemophilia. And this severity actually determined by the level of clotting factor that's present in the person. So clotting factor level can be described either in international unit per deciliter or in percentage. So the bleeding manifestation also you can see from this, you also can get this slide from the CPG that I told you, that I showed just now. So actually if for severe hemophilia, there will be a spontaneous bleeding into the joints or muscle, predominantly in the absence of any identifiable hemostatic challenge. There's nothing that provoke the bleeding, but it's just suddenly can spontaneously bleed. In moderate hemophilia, there's occasional spontaneous bleeding, there's prolonged bleeding with only minor trauma or surgery. But in mild hemophilia, spontaneous bleeding is rare, but the bleeding is severe when there's a major trauma or surgery. So actually, if we look at the previous slide, then you will, it's kind of too much. Actually, we can see the correlation between this factor level and the severity just by look at this pyramid. So the pyramid shows that there's inverse correlation between manifestation of bleeding in the patients and the factor level. So meaning the lesser the factor level, the severe the type of hemophilia is. So and we must bear in mind, actually clinical symptoms are only the tip of the iceberg. Subclinical bleeding can also occur. So so we can see that if less than 1% or 1 international unit per deciliter, it is severe type. 1 to 5 international unit per deciliter is actually moderate type of hemophilia, while mild is 5 to 40 international unit per deciliter is a mild type of hemophilia. So, like I told just now, bleeding severity correlates with clotting factor level. So, this is what I mean just now by the severity. So, basically, mild hemophilia always like late recognitions, or usually in early child, like in the childhood, adulthood a bit, and patients are often underdiagnosed because typically they don't have spontaneous bleeds and the bleeding is uncommon. But for moderate, within age 1 or 2 years, there will be a bleeding. So, and their bleeds is about 12 bleeds per year. So for severe hemophilia, before the age of 1 year, there's already a spontaneous bleed, and they have like incidence of bleeds 24 to 48 times bleeds per year. Okay, so how do we diagnose a person who has hemophilia? So there's basically two type of testing, which is laboratory testing and genetic testing. So screening tests for suspected hereditary bleeding disorders will include prothrombin time, PT, activation partial thromboplasticity, APTT, and platelet count. But if a person has normal prothrombin time, normal PT, prolonged APTT, and the platelet count is normal, so we must suspect the person to have hemophilia. And then if there's a positive family history, we must do the factor 8 and factor 9 assay to confirm the deficiency of the coagulation factor. So, hemophilia treatment, just for a hemophilia hemophilia person, there's four treatments that we offer to them, which is basically pharmacological, adjunctive treatments, analgesia, and also non-pharmacological. I will not talk about more of the non-pharmacological factor because basically based on the joints, on the other part of the body if the bleeding occur, but basically I just mentioned that non-pharmacological include rehabilitation of the musculoskeletal, price, joint protection, sports and physical activity. It does not mean that persons with hemophilia cannot do sports, but they must do sports because they need to have a healthy movement. Okay, so but it also must based on their factor level, bleeding history, and their physical health. Post-op care and weight management. This one is all because base is actually to protect their joints. So I will further discuss about pharmacological adjunctive treatments and analgesia for person with hemophilia. So pharmacological treatment for person with hemophilia basically is factor replacement therapy or clotting factor concentrate. So it can either be on demand, means when there's an episode of bleeding, we give, or via prophylaxis, that means this patient has regular infusion of clotting factor concentrates. And there are two types of clotting factor concentrate, which is plasma derived factor, which I will say is PDF. It is manufactured via fractionation of human pool plasma, but it has higher risk of bloodborne infections. But the other types of clotting factor, the other type of CFC is recombinant factor. It is manufactured via DNA engineering technology. So this is the factors that are available in Malaysian market. So I'm not really promoting any, but this is just for our sharing knowledge that you can see that there's factor 8 plasma derived, like factor 8 recombinant. Factor 8 from plasma derived, you can see there's the many supplier, also factor 8 recombinant, factor 9 plasma derived, and factor 9 recombinant. So pharmacological, so just now I mentioned about prophylactic and on demand. So basically prophylactic factor replacement therapy is a regular infusion of plasma factor in an attempt to raise the clotting factor levels and to keep them at least 1% or higher at all times. So basically this is for severe hemophilia. And then should be given to all persons with severe hemophilia, and primary prophylaxis should start following intracranial hemorrhage if it's present during birth or during the infancy, first joint bleed or severe intramuscular bleed, or by the age of 3 if there is no major bleed, whichever comes first. So however, the concerns with using plasma-derived factor is blood-borne infectious disease, especially the unknown yet to be discovered viruses which may escape the current viral reduction process. Because you know all these plasma-derived factor, they actually undergo viral reduction process, but there's always an unknown virus that actually can escape this. So in view of risk of blood-borne infection with plasma-derived factor, recombinant factor is the preferred choice for factor replacement in hemophilia. However, okay, in giving the factor replacement therapy, inhibitors development is the most serious complication for these persons with hemophilia. So what is inhibitors? So we need to understand also what is inhibitors. Inhibitors are actually antibodies that neutralizes clotting factor which develop following factor replacement therapy. So the presence of these inhibitors actually lead to ineffective factor replacement therapy. This screening for inhibitors should be done in all persons with hemophilia exposed to factor replacement therapy. Am I going too fast? Because I have many slides, I just want to finish it fast. So, so like I said, the first treatment is pharmacological treatment with the clotting factors. And the second treatment is adjunctive treatment. This is either with desmopressin or tranexamic acid. So actually desmopressin is a synthetic analog of vasopressin that boosts plasma level of factor VIII and von Willebrand factor in mild to moderate hemophilia. So in mild to moderate hemophilia, desmopressin certain subtypes of von Willebrand disease. So it's applicable only in minor form of bleeding. It should not be used in moderate to severe form of bleeding. But it's also contraindicated in children less than 2 years old who may be at risk of seizure secondary to cerebral edema due to hyponatremia. So the second adjunctive treatment is tranexamic acid. It is an antifibrinolytic agent. It promotes clot stability by inhibiting the activation of plasminogen to plasmin. So it is useful in controlling bleeding from skin, mucosal surface, which is actually helped us a lot, especially in oral bleeding, epistaxis, and in menorrhagia. So, but it should not be used in the treatment of hematuria, as it may prevent dissolution of clots in the ureters, which may result in obstructive uropathy and potential damage to the kidney functions. So it can be administered systemically to prevent post-operative bleeding and reduce the need for clotting factor concentrates. And tranexamic acid is actually available in 3 preparations: in oral, IV, and mouthwash. So in centers where mouthwash is unavailable, the oral form, either in tablet or capsule, can be dissolved in water and subsequently used as mouthwash, 5% weight in volume or 500 milligram in 10 milliliter, and the dose is 15 to 25 milligram per kg per dose every 8 hours. So this 5% tranexamic mouthwash actually can be used 4 times per day in the mouth for 2 minutes before discarding. It means if there's any bleeding in the mouth. And oral tranexamic or 5% should be prescribed pre or post-dental extraction for up to 7 days. So compression of the bleeding area using gauze soap with diluted tranexamic also is still used until the bleeding stops. So the third treatment is analgesic. So analgesia should be offered for pain relief according to pain severity. It means if dental treatment, we do dental extraction pains, hemophilia patients with dental pain or joint pain, so we should give them analgesia. So first and foremost, we must do a pain assessment. So for pain assessment, as we all know about pain as 5 vital signs, 1 to 3 years old and adult patient who are unable to communicate verbally, we can use flex scale. More than 3 up to 7 years, we use visual analog scale. We don't use the Wong-Baker scale because there's Wong-Baker has for Ministry of Health, we use visual analog scale. So for 7 years, more than 7 years and adult, we use the numeric rating scale. I think everyone has seen this scale, right? The face scale, the numbering scale. So for mild pain, we can give paracetamol and strong opioids. So avoid to give aspirins to patient for pain control for person with hemophilia. So even if you want or etrocoxib or temerdol codeine, then we must understand the effectiveness and safety where it's not established in children. So this one also you can also refer it back to the clinical practice guidelines. Okay. Okay, so apart from clotting factor concentrates, factor replacement therapy, adjuvant therapy, analgesics for pain, there are also options for a person with hemophilia to have home therapy. But this one is done outside of the hospital, but its safety and effectiveness is closely supervised because it's important because it allows immediate access to clotting factor, because the earlier the factor is initiated, ideally within 2 hours of bleeding onset, the faster the bleeding will resolve. That's why home therapy is actually exists for persons with hemophilia. So other things I want to share about hemophilia is the vaccination. So all injectable vaccination in hemophilia will be given by subcutaneous rather than intramuscular. And also circumcision is not especially ritual circumcision is not obligatory for its life-threatening risk in person with hemophilia. So this one, I think, through the CPG, they said that it's actually already being discussed by Muzakarah Jawatan Kuasa Fatwa Majlis Kebangsaan bagi hal ehwal agama Islam. So basically it depends lah. So it's from the Majlis Fatwa, it's actually not obligatory because of its life-threatening risk. So so we go to our our specific to dentistry or pediatric dental. So treatment for acute bleeding in specific site or oral cavity. So in person with hemophilia, bleeding in head, neck and GIT is a medical emergency. So factor replacement should precede investigation. So the initial factor replacement therapy is to raise the factor level up to 100 international unit per deciliter or 100%, because its aim is to achieve factor level of 100% for life-threatening bleeds. So acute bleeds in person with hemophilia should be treated with factor replacement as soon as possible. Like I said, preferably within 2 hours. So however, the desired factor level is actually depend on site and severity of bleeding. So usually it's given until the bleeding is resolved. So this table also you can see it from the CPG. So what I would like to highlight is it's actually hemophilia A and hemophilia B. Hemophilia A and hemophilia B, actually there's a desired level and durations that we want this desired level of the factor. Like for our part whereby dental extraction is considered as minor surgery. So pre-op, we desire the level of the factor to be 50 to 80. And then post-operatively, it should be between 30 to 50. And then usually we want this to be like this for 1 to 5 days depending on the type of procedures. So for deep restoration, also the same 50 to we want the desired level. I'm talking about hemophilia A, okay? So for deep restoration, we desire the level to be at 50. However, for throat and neck, you can see the other part, it needs higher level, like for CNS, for throat and neck, for GIT, for deep muscle, there needs a higher level of factor if there's an acute bleeding lah. So that's why it's different, depends on the sites and surgeries involved. So hemophilia B, the factor level also a bit different, but there's a guidelines for this on how much the desired level for hemophilia A and B, and depends on the hemorrhagic type. So this calculation, I don't think we are doing it. Usually being done by the hematologist. So, but it's just for me to share with you all. There is a formula to calculate the dose for factor replacement. Okay. So Dental care for person with hemophilia. Okay, management of oral bleeding. So causes of oral bleeding in person with hemophilia include eruption of permanent teeth with exfoliation of baby teeth. So physiologic process of tooth eruption and exfoliation may be attended with severe prolonged bleeding, like you can see in the picture that I get from Google image. So the first picture here is actually the severe bleeding gingival hemorrhage due to exfoliating canine. So usually it is prolonged bleeding. So and then gingival gum bleeding associated with oral hygiene, also trauma. Like this boy, hemophilia, he has trauma to the frenum and it causes severe bleeding for frenum. Usually, if normal patient with laceration wound or torn frenum, it will not have this excessive bleeding. But in person hemophilia, when the patient has only torn frenum and the bleeding is quite excessive, so maybe we can bear in mind, at the back of our mind, to investigate further on the underlying cause. So other cause of oral bleeding in person with hemophilia is invasive dental procedures such as dental extraction or surgical procedures. So in children with hemophilia, the surrounding gum may appear bluish and swollen when the baby teeth erupt. So normally, in normal patient, it is not bleed. Okay, in hemophilia patient also it's not bleed normally, but it can bleed. So it is suggested to allow baby teeth to self-exfoliate in order to minimize risk of bleeding. However, in local setting, if the baby tooth is mobile and causing the gum to bleed, then maybe extraction is indicated. So when the extraction is indicated, so the need for factor coverage, you should discuss it with the hematologist involved in treating the person with hemophilia. So type of dental procedure also significantly affects the bleeding outcome, and it can be categorized according to risk of bleeding, meaning high risk procedures have higher bleeding outcome compared to low risk procedures. So in the CPG, actually the CPG already classify high risk dental procedure and low risk dental procedure. So high risk dental procedure include flap elevation, teeth extractions, crown lengthening procedure, soft tissue biopsy, scaling and or root planning, and inferior alveolar nerve block. Whereby a low risk will be restorative treatment, okay, filling crown bridge, prosthodontic treatment, denture fabrication, root canal treatment, or orthodontic treatments. Okay. So antifibrillary agents like tranexamic acid and epsilon aminocaproic acid therapy is administered systemically in person with hemophilia undergoing minor oral surgery or dental extraction are beneficial in preventing post-operative bleeding. So the antifibrillary agents actually reduce the need for clotting factor concentrate and post-op bleeding. So previously no significant adverse events have been reported. So like this one, I think I've speak about it just now. So actually, for bleeding in the mouth, like you can give the antifibrillary in the form of tranexamic acid mouthwash 5% 4 times a day, kept in the mouth for 2 minutes before discarding. Means it's not like you just gargle, not even a few seconds, and then no, it should be in the mouth at least 2 minutes and 4 times a day. So you can either prescribe oral tranexamic with combination or alone with 5% tranexamic acid mouthwash for dental extraction up to 7 days. But be careful not to give the mouthwash to younger children, as they may inadvertently swallowing it, leading to overdosage. So sometimes I think I still need to give children the tranexamic mouth, but usually I will soak the gauze with the tranexamic, so not asking them to gargle, soak it, and then ask them to bite or give pressure to it. So it's a patient to patient basis, so to see how the level of the patient's cooperativeness or compliance. So in local, this one, okay. In local setting, compression of the bleeding area using gauze soaked with diluted tranexamic is used until the bleeding stops. This is the method that I usually use. So in person with hemophilia who are undergoing dental extraction, bleeding may be minimized by using either resorbable or non-resorbable sutures. You can also use surgical splints and other additional local hemostatic measures. So meanings, apart from giving tranexamic acid, you also can suture the extraction sites, or if it's not able to give sutures, or you can do surgical spleen or add on any local hemostatic measures. So, but factor replacement also may be required, tapi we have to discuss further, and we must also talk to our hematologist for the post-op care plan. So preventive dental measures. So according to the CPG, actually comprehensive oral health care should be initiated as early within 6 months of the first tooth erupts and no later than 12 months. So whenever a child is diagnosed with person with hemophilia, they should be referred to us for our comprehensive oral health care, because they need routine dental examination with preventive care measures that must be carried out throughout their life. So good oral hygiene practice and dietary counselling should be advocated to prevent dental disease in person with hemophilia. So it is advisable for oral health assessment within 6 months of first tooth eruption. So like, normal preventive dental measures, so they have to brush their teeth twice daily using soft bristle toothbrush with fluoride containing toothpaste should be advocate. Dental floss and interdental toothbrush should be used whenever possible, okay, but with care. Early childhood care is a significant oral health related disease of young children. So dietary counselling, including reduced sugar intake, should be a part of oral health advice in person with hemophilia, and properly designed health educational programs are helpful to make positive changes in person with hemophilia. So effective and safe dental procedures. Effective and safe, that is the most important phrase that I want to emphasize here. Effective and safe dental procedures should be a priority in person with hemophilia. Comprehensive oral health care in hemophilia should be performed by a multidisciplinary team, which include a dental surgeon. So before performing any invasive dental or surgical procedures, the dental surgeons must liaise with the hematologist in order to prevent or minimize potential bleeding or infection risk. So careful planning for hemostatic cover is crucial, okay, for person with hemophilia, especially if the person with hemophilia has inhibitors. So like I said, dental surgeon is part of the multidisciplinary team in hemophilia comprehensive care. So for local anesthetic procedures or the factor replacement therapy recommendations. So basically, procedures that do not require factor cover, but this one applied for adult patients only. Pediatric patients may receive factor replacement therapy before local anesthetic infiltration as advised by hematologists. So for adult patient, labial, buccal infiltration, intrapapillary injection or intraligamentary injection might not require factor cover, okay, but for pediatric patient, please discuss with your hematologist. And then for procedures that require factor cover, and this one applies to both adult and pediatric patients, is inferior dental block or mandibular block and lingual infiltration. So but in local practice, inferior dental block or lingual infiltration are best avoided for pediatric patients. I mean, if we can go not to give this, then we have to find a way not to do this procedure for person with hemophilia. However, if we do, then we have no escape and still have to do it, then we must discuss with our hematologist about the factor cover. So locally, there's different type of dental local that were being used, like mepivacaine, lignocaine, and articaine. Okay, articaine hydrochloride 4% with 1 in 100,000 epinephrine has been described as an alternative to inferior dental block in the restoration of mandibular molars and may remove the need for preoperative factor cover, because we want to avoid giving ID block. So basically, maybe we can change to other type of local like articaine. Okay, but worst come to worst, if there's no articaine, then we have to discuss with our hematologist. Okay, and then we must advise our patient or with hemophilia, they must seek immediate care from hematologist or dental surgeon post-operatively if one of these events occur, which is prolonged bleeding, difficulty in speaking, difficulty in swallowing, and also difficulty in breathing. So local anesthesia with vasoconstrictors may provide additional local hemostasis. Buccal infiltration is usually sufficient to anesthetize all the upper teeth and lower anterior and premolar teeth. But like I said, inferior alveolar nerve block only can be given if we have increased the clotting factor level by appropriate replacement therapy, as there's risk of bleedings. Okay, the intraligamental technique or intraosseous technique should be considered, but this one more on adults. And if patients need GA, then we might consider to ask for oral intubation rather than nasal intubation. Okay, Surgeries. Okay, surgeries and invasive procedures. So surgery, if we want to schedule for surgery for patient with optimal, we need educate the patient for monitoring factor level, because we need to test whether the level has dropped or whether there's inhibitor. So adequate quantities for factor concentrate must be available perioperatively during the healing and rehabilitation. We cannot say that when there's a bleeding incident, there's no factor level and things like this, because this is life-threatening condition. So we must plan properly, okay, schedule early. So the use of clotting factor replacement therapy is advisable for all invasive surgical intervention in person with hemophilia, and surgery must be performed with caution to reduce trauma to the soft tissues. Okay, this one also I think I've mentioned it, so I think I'll skip this slide. How about prosthetic or orthodontic treatment? So orthodontic treatment or removable prosthesis is not contraindicated. However, these appliances may encourage plaque accumulation, which necessitate vigorous oral hygiene programs. Okay, like in this picture, this patient is actually hemophilia orthodontic patient with presence of gingival hemorrhage. Malocclusion or such as overcrowding can lead to periodontal disease if left untreated. So it will have a bleeding tendencies or bleeding risk. Therefore, an orthodontic treatment or assessment for person with should be considered between the age 10 to 14, which is in the late mix or early permanent dentition stage, because we want to avoid periodontal disease if we leave the overcrowding problem untreated. Okay, so endodontic treatment actually is favored than extraction. Whenever possible, go for endodontic therapy. Okay, it is more favored in person with hemophilia, and the working length of the root canal should be calculated precisely to ensure that the instrument do not pass through the apex of the canal during root canal treatments. So periodontal healthy periodontia is important to prevent extraction, tooth loss, and bleeding. Supragingival scaling can be carried out, like I said just now, in the procedures with risk of bleeding skin, with oral hygiene instruction followed by subgingival scaling after the inflammation has subsided. So the take-home message for today's I'm going too fast. Okay. So the take-home message of pediatric dental management for person with hemophilia. First and foremost, everyone must know the assessment and diagnosis. Like, that's why I tell you everything about hemophilia, so that you can recognize. You can question yourself. You can get a proper history, so that this it will help you in planning your treatments. Okay, so when you already got all the informations in details, and you know the condition, you know the type, patient has inhibitors, which type, severe, mild, moderate, if severe form, what's their treatments on, whether they are on clotting factor concentrate, clotting factor concentrates treatment, or there's for adjuvant therapy. So you must know in depth on patients' hemophilia conditions, hemophilia treatments that they receive. Then only you can talk in par with your hematologist, so that you can make a proper decision making in treatment plan and the policy. So when you have that in mind, then only you can do your then only when you have a treatment plan, then you must understand which procedures will cause more bleeding, which procedures is not cause more, which procedures need clotting, need factor cover, which procedures doesn't need factor cover. So after that, then when you have decided your treatment plan according to patient's conditions, then only you must prepare yourself for pre-operative and the replacement therapy, and then the choice of anesthesia that you want to give, local or GA or analgesics that you want to give. But this patient also, you must understand that when you treat the patient, it's not just end there. Post-op care is also important. And what do you have to do? Maybe give adjuvants like tranexamic acid, so that for how many days, so that patient don't have complication and come back to you after your procedures. So as a conclusion for today's talk is hemophilia is a complex disorder, okay? Wide-ranging needs of person with hemophilia and their caregivers are best met through a coordinated, comprehensive and multidisciplinary care by team of healthcare professionals in accordance with accepted protocols and national CPG. That's why I'm again, that's why I promote this. Everyone's to read this. It's actually quite good. So it's very good, not quite good. It's very good guidelines because it's comprehensive with also the what we call that, their recommend with the key recommendations and also the evidence. It is with evidence-based recommendations. So effective and safe dental process should be a priority where a careful planning for hemostatic cover is crucial. Okay, with that, I thank everyone for listening to my talk. And I'm so sorry because I go too fast. I thought I will take your time more. So with this, I end my talk and I would like to promote for our next webinar in September, which is anesthetic consideration for pediatric patients, will be given by Dr. Yoga Bhavani and will be moderated by Dr. Nabila Sawani. With that, I thank you very much. Thank you for listening to me. Okay, go back to Dr. Nazar. Okay.
Yeah, thank you, Dr. Rosie, for the very comprehensive and informative lecture. I think this topic is rarely discussed among us, but I'm sure there are lots of cases has been seen whether in clinic or hospital. So thank you so much. It's very informative. Okay, I think we have one question in the box. Right, so the question is from Dr. Amira Hanis. Thank you, Doctor, for the superb presentation. The question, in case ada hemophilia patient comes to our KP, patient really in pain and want to do extraction, what are the steps that we can do as a new dental officer? Kadang-kadang panik bila dapat patient hemophilia. Kita semua pun akan panik tu.
Okay, sebab tu lah. Okay, I'll talk in Malay lah. Okay, that's why I said when we when we face the patients, we must know in depth their medical condition. So when patients come with hemophilia, you must first hemophilia A or B. Okay, you must know that first. So you must understand the disease itself, the condition itself. Okay, A or B. Okay, A. So A and B also they have mild, moderate or severe type. Okay, so usually if they are diagnosed in a very young age, usually there are severe type or moderate types, because like I said, in the mild type usually they diagnosed in early adulthood or maybe late childhood lah. So basically when you know whether it's mild, moderate or severe or the hemophilia A or B, and then you must know if are they on treatment, are they on factor cover prophylactic or on demand. So when they are on prophylactic factor cover, when they are on regular factor cover, because there's also whether they 2 or 3 times factor cover a week, and that will under their types, whether there's mild or severe or mild, moderate or severe, there will be their frequency of factor cover. So when you know about the disease itself, and then you know what type is it, and then you know what treatment do they need. Because actually when you want to refer to a specialist also, you must tell us all this, because after then you have to, then if patient is on routine prophylactic cover, so like I told you, you must understand about whether patient has inhibitors or not, because we know patient with hemophilia, patient with inhibitors actually impose quite a problem, because the fact it has antibodies to reduce the factor. When we give factor cover, it's ineffective. So basically when you have all that, and then it's severe form, it's moderate type, it's severe type, I think it's better to refer to center whereby there's a hematologist, and the like I said, you must have a lab to what we call that to screen their factor level, and also must have factor cover, so that, because we want to know extraction, like I said, extraction is also one of the dental procedure that needs factor cover. So I think for KP, you shouldn't simply extract, okay? But even for mild hemophilia, because sometimes you might be able to control the bleeding in the clinic, but when patient go back, the bleeding will be non-stop and the patient will come back. So it will be like messy and you have to refer to the hospital after office hours. So basically, I think for dental extraction, it should be done at hospital with support, because it needs multidisciplinary like lab, like hematologist and also the dental specialist. But it's important for officer to understand the disease when you want to refer, so that all these questions will be asked by your specialist. Okay, I hope I answered the questions.
Right, thank you for the answer. If you have any questions and you don't want to type in, just switch on your microphone and you can speak and ask Dr. Rosie. I have one question, Dr. Rosie. Okay. Is there a designated hematology center for pediatric patient? If yes, where is it?
Okay, actually nowadays usually they say it's in the I'm not sure about, but I'm not sure about that. If I'm not mistaken, I'm sorry if I'm wrong. Now it's in Hospital Ampang, is considered as one of the hematology center. However, they want to no longer make it a center for hemophilia treatment. So they want to disperse that every state and every district, every state in Malaysia can treat these hemophilia patients. So we call this hemophilia treatment center. They want to establish hemophilia treatment center in every state. So currently, I'm not sure about the development of the plan, whether it's already in plan or still in plan or it's already being worked out. But currently it's in Hospital Ampang. I think HKL also have, but I have to ask my my jawatankuasa in hemophilia in the Ministry of Health, because I'm not one of the jawatankuasa for National Hemophilia Ministry of Health. So it's Dr. Suryani for Pediatric Dental.
Right, thank you. Good to know, because at least we know where to refer or just refer to any specialist in the hospital base, I think. Okay.
It's okay, Nazato. I think as long as the hospital has hematologists, I think you can refer to that place, because if I'm not mistaken, Ipoh they have hematologists, Hospital Ipoh. There's certain hospital that has hematologists in-house. So for certain hospital with hematologists in-house, I think it's no problem to refer. Like Ampang, like HKL, like Ipoh. I'm not about other hospital I'm not aware of, but I think Ipoh, Ampang and HKL I'm aware of. There are hematologists in the house. So that hospital is actually can, because nowadays, because factor they want, usually those days the factor only in this certain hospital with hematologists present, but nowadays I think they want to distribute and disperse the service to all in Malaysia. So it's easier, we reach out for the patient or patient reach out for us. I think that's the plan.
That's great to know. Okay, if we don't have any question, but you can always ask question to in our post when we post it in Facebook and Instagram. Maybe we can forward it to Dr. Rosie later. Okay, I have a few things before I wrap up the webinar. As you know that this Google Meet is only allowing 100 participants. So for today, we are actually running a YouTube live platform. So I think inshallah in the next webinar, we will share it earlier. So, but I encourage you to join our Google Meet first before going to the YouTube live. And then another thing is I would like to encourage all participants to join our association as a member and visit, follow and like our post on MAPD, which is on Facebook. It's a Malaysian Association of Pediatric Dentistry, and Instagram official MAPD. And there'll be there is a current running contest, which is a photography contest. I would like to encourage the dentist to join the contest, because the image will be used for the coming journal. Right. I think if there's nothing, then I would like to remind you to also fill up the attendance form, the Google form in the chat box. And I think that's all for today. Till then, bye. Thank you for participating.
Thank you, everyone. Nice to have you all. Thank you, Nazatul.
Okay, thank you, Dr. Rosie.
Thank
Bye.
you, Faizal.